So with that, we're going to shift gears slightly to our next session. I'm going to invite um, that slide. Thank you. So part two of part one is going to focus on looking at how the PCORI method of patient engagement differs from what we just heard and we're discussing with respect to the CAHPS approach. PCORI stands for the Patient-Centered Outcomes Research Institute. And our aim in doing this is to gain some insights into different ways that patients can shape research and evaluation studies. And I think the contrast and comparison is going to be very, very interesting. Our two speakers, if you can go to the next slide. Okay, great. Karen Sepucha serves as director of the Health Decision Science Center at Mass General Hospital. And she will be joined in our kind of partnership of research and patient co-investigation is Susan Strong, who serves as a patient co-investigator on several PCORI studies focused on shared decision-making and patient-centered outcomes and others. Again, their bios are on the event site. I encourage you to go and look at them, and that's where their slides will be, as well as other resources that they have both offered for your use moving forward. But I will say that Karen is also an associate professor in medicine at Harvard Medical School. She's led many groundbreaking efforts to advance shared decision-making among many health systems around the country, and in that role has been very instrumental to the CAHPS survey development team in thinking about ways that patient experience surveys can address and measure shared decision-making. Susan is a nationally recognized patient advocate and a former director of what was called the Patient Engagement for Heart Valve Voice US, which is a mouthful. She has a background in education and communication and brings over a decade of experience in advancing what you will now witness as meaningful patient involvement in research and clinical care. So again, thank you both, Karen and Susan, for this part. And I'm going to turn it over to you, Karen, to kick it off.
Great. Thank you so much. Thanks, Dale, for the introduction, and for AHRQ and the CAHPS team for highlighting this area. We're really excited to be here to talk about the work. So we're going to go to the next slide. Could you go back to that first slide? Thanks. Talk about the lived experience at the table. So we will be talking about putting that PCORI model into practice. As Dale mentioned, I'm a researcher at Mass General and Harvard, focusing in shared decision-making and, developing interventions, measures, clinician training, trying to figure out how do we really make sure that patients are well informed and that they're meaningfully involved in decision-making about tests, treatments, and their health care. I just want to turn it over to Susan, my co-presenter today, to just say a quick hello, and then we'll get started with the talk.
Thanks, Karen. Thanks, Dale. I'm a patient advocate and consultant focusing on patient engagement and research. And as Dale said, I'm the former director of patient engagement for Heart Valve Voice US, and really thrilled to be here. I'll turn it back to you, Karen.
Great. So you can go to the next slide. So what we just heard from the CAHPS team and from Susan was, I think, a really great example of patient-centered research. And the team is really excelling at making sure that patients' experience is captured and measured. And in this healthcare world where we manage what we measure, making sure that we have the patient's voice systematically collected so it can be put into the, used to guide improvement activities and to help us understand how we're doing is really critical and important. So while we think patient-centered research is core and very important, it is actually not the same thing as engaging patients in research. And so that's what we're going to be talking about in our session today. And I think, as Maura mentioned earlier, this is a little bit about moving from that participatory design to an idea of co-design. So, how do we take this to that next level where patients are meaningfully engaged in the research itself and have a substantial decision-making role as part of the research team? So you can go to the next slide. And we'll be talking a bit about the Patient-Centered Outcomes Research Institute, or PCORI. And this is a not-for-profit organization. It was established back in 2010 through the Affordable Care Act, and it's charged with conducting comparative effectiveness research. It is a government-sponsored group, but it is not part of the NIH. And its mission, as put up here, is really to help people make informed healthcare decisions and to gather evidence and information to help them do that. And that research is really supposed to be guided by patients, caregivers, and the broader healthcare community. And so from the start, PCORI really has challenged the research community to rethink how we are conducting research. And specifically, it has required meaningful engagement of patients and families as research partners. And, this is evolving over time, and, encouraging folks not just to have an advisory board, but also patients as co-investigators or even principal investigators on these research grants. And so that's, that model that they're really moving towards and trying to support researchers in the whole field to move towards that model. So if we go to the next slide, which might be a poll. So we have a poll. We were just really interested, obviously, in the group here today. What is the highest level of experience, from the folks in the audience that you've had with patient partners on either a research or a quality improvement grant that you've worked on? And I think that input level, which we're seeing, is really what we heard a lot about from the CAHPS team, doing lots of focus groups, surveys, interviews, observations. So making sure that that voice is in there, and then a bit less on the, maybe an advisory board. Maybe a few people have had some experience as co-investigator and a few as PI. Okay, great. And I think this is probably a lot more engagement than actually other, like other groups might have. You can go to the next slide. So this quote is from actually a researcher on the PCORI website, but I think it really illustrates some of the learning curve in trying to think about this and do this work. And so the research is saying, my attitude was pretty typical. Let's find some patients and families. I can put them on my grant. We'll have a meet every once in a while, and then I'll check that box. And as it progresses, I think if you just click a little bit to get the next part of the slide on. As it progresses, I think the experience, and certainly for me, this is actually follows pretty well my experience that, after we got that patient advisory group together, after we built some trust, had some meetings where they understood and felt comfortable with us, understood what we were trying to do, it really started to become apparent that the partners had things to add that we hadn't even been thinking about at all. And it went from a notion of having an advisory board to really understanding that if this is going to work, they have to actually be central to this whole thing. And so while this quote isn't mine, it does really do a great job of reflecting my initial experience. So for example, one of our grants, we had an advisory committee. This was part of a quality improvement research project, integrating patient decision aids into routine care. And it took a few months to get our team together and to get our advisory members comfortable with each other, comfortable with us, comfortable with what our aims were for the project and what was involved. They'd all had personal experience with, this was about surgical treatment for, hip or knee replacement. And then they started to increase their input. And, in one example, while they really liked the patient decision aids, the educational tools we were trying to integrate into routine care, they also challenged us not to lose sight of this goal of shared decision making. And their sense that if we're really doing shared decision making, then the doctors need to listen to us and respect our patients' goals and preferences. And then they challenged us to say, how are we doing that? How will we know if those doctors are listening? And so that led us to design a new intervention that we tested in our next study. And it also led us to change the outcomes that we were collecting to make sure we were surveying the surgeons to figure out, what was their perception of the patient's goals and preferences? And before that, we probably would have been just working under the assumption of, if we want to get the surgeons to sign on to this study, we can't ask them to do anything extra. But they really challenged us, thinking about what does shared decision-making mean, and helped us dismantle some barriers that we had put up that, once it kind of came from the patient partners, it had more of a value and an authenticity, so that when we went to send it to the care teams, they were able to, actually accept it. And we actually good response rates and good experiences with that. So if you go to the next slide. So PCORI has a framework, and they put together lots of resources to try to help researchers do this and put this into practice. So they set out clear expectations for what patient partnership means, and we'll give you some more resources later, but they also have, real accountability to make this happen. So as part of your, 12 to 15 page research proposal, several pages is dedicated to your engagement plan. How are you putting patients and families or other community groups, how are they sitting at the table? What is the roles and responsibilities? Is there representative involvement? Have they been involved from the design phase? It's not something you're going to put together a year into your grant, but they've actually been involved in the design of this study. Have you had dedicated funds? Have you budgeted sufficiently for their participation? And are you valuing and compensating them for their time and effort? How are you building capacity to work as a team? What kind of training and things do you have in place? What is their role in the decision-making process? Have you really thought through that? Which areas might they have decision-making roles in, authority? How are you sharing that? And then what are you doing in an ongoing process? If this is a 5-year grant, how are you going to be learning and measuring and making changes over time? And PCORI itself holds itself accountable. So anybody here who's maybe been involved in a PCORI project might also be aware that when you submit your proposal, the review committee it gets reviewed by 5 people. It gets reviewed by 2 researchers, 1 statistician, and 2 community patient partners. So they're at the table when they're making decisions and voting on research projects to say, is this valuable? Is this meaningful? So it's not just a check the box for PCORI, it's the way that they've sort of organized themselves as well. You can go to the next slide. And so now I think I'm going to turn it over to Susan to talk a bit about her experience moving from a subject as a patient to a stakeholder partner.
Thanks so much, Karen, and thanks everybody for having this discussion today. I think it's very exciting that we're here talking about this and talking about the evolution of patient engagement in research. If you can forward the slide, it has an animation, so there's one more. Yeah, there we go. Thank you. Nope, sorry, back to the previous slide, just the animation hadn't come up. There we go. So I'm going to talk a little bit about just moving from subject of research to stakeholder in research. And as Karen mentioned, PCORI has been so instrumental in shifting frameworks from patients as subjects to patients as stakeholders, partners, advisors, collaborators, consultants, and co-creators in research. And I'm actually currently involved with another study that's called the Co-Create study that's led by Monica Perez Yolis from the University of Colorado. And her study is one of numerous PCORI-funded projects that are emphasizing collaboration and co-creation between researchers and community members, such as patients, caregivers, and other diverse populations. And these studies are developing patient-centered comparative effectiveness research, CER, by building capacity and fostering trusting relationships, creating practical interventions that reflect the needs and preferences of all the stakeholders that are involved. And this Co-Create study is actually creating a measurement to measure the level of co-creation that's happening among the stakeholders on these teams. Next slide, please. And so from PCORI, we get this information about the levels of engagement that we want to try to look for when we're involving different stakeholders. And the goal, of course, is to aim for the bullseye. And as I mentioned, the Co-Create study is developing a validated and usable measurement for co-creation in the research project or researching process. And with PCORI, the consultant level is considered kind of the minimum level of engagement, and we want to encourage higher levels, of course. Next slide. So we're all familiar with the various stakeholders that are engaged in research, and I've had the opportunity to participate in studies and meetings and collaborations that engage a broad base of stakeholders that include representatives from regulatory agencies, clinicians, researchers, patient experts, industry, payers, And the lived experience from all of these stakeholders really offers a rich tapestry of out-of-the-box thinking, giving ideas and possible solutions and unique perspectives, and even new definitions of problems that just wouldn't happen if we didn't involve this wide range of stakeholders. And an opportunity for all of us to think about after this meeting today is to reflect back and think of, what voices are currently missing from the discussions and the research that's happening, and how can we increase that engagement. Next slide, please. So we know that patient experience is key in both CAHPS and PCORI. And I'll share an example of a partnership with patient advisors that had a decision-making role in the impact share decision-making study that Karen is currently leading. And in a meeting, the researchers were talking with our patient advisors, and they were working on creating a measure to determine the patient's level of understanding about their treatment choice, and their preferences for treatment as part of the study materials. And the patient advisors kind of pushed and kept asking about, are we tracking anxiety and fear and the emotional impact of diagnosis and treatment? And all of the advisors in this meeting were really in strong agreement about adding this. And the researchers and the team decided to integrate it into the study. And this is an example of valuable information that wouldn't have been included if it hadn't been for patient advisors. And next slide. So in the last decade or so, patient involvement in research has evolved tremendously, especially because of the leadership from PCORI. And my own engagement in research has changed from the very first involvement, where I was a mostly quiet observer, wondering myself what I had to contribute to this group of leaders, to moving to a point where I actually was the project lead for a Eugene Washington Engagement Award with Heart Valve Voice US. And we created a building and educating heart valve disease network prepared to engage in research, and created a training that was called Valve in Research, Valuing Advocates' Lives, Voices, and Experience in Research. And the goal of the course that we created was to increase knowledge and competency and ability of patients and caregivers to become meaningful partners in research, while creating practical connections among these patients, researchers, and additional stakeholders. And the long-term objective of this training is to increase the number of patients engaged in research and dissemination activities with federal agencies, PCORI, and other stakeholder efforts. In this Valve in Research course, we created 6 training modules, and patients engage with faculty representing perspectives of researchers, regulators, medical technology innovators, payers, advocates, and others. And the training is delivered through a patient community, and it resides within the community and has ongoing support. And if anybody here at the meeting today is interested in seeing this, using it as a training tool for patients that you might work with, or as a reference, I invite you to reach out to me afterwards at susan@susanstrong.com, and I can help you access the training at no cost. And next slide, please, and I'll turn it back to you, Karen.
Great. So I think we heard a little bit earlier about some of the how this is just a new kind of paradigm for researchers, and it's also a new paradigm for patients and what their expectations are, how they experience this, and as Susan was mentioning, the need for training to really make sure that they feel competent and confident in really full participation. This is a testimonial from one of our patient partners who's involved in one of our early projects. sort of saying I wasn't really quite sure what I was getting into when I joined this, but really reflecting on the experience as one that was, really valuable for them. Gathering, sitting at the table with surgeons and others, really had this sort of thinking out of the box quality that's probably the key to advancing in patient care. And, I want to share one more example from this patient partner, actually, of how having sort of patients at the table really can change conversations in fundamental ways. So this project, again, was about getting decision aids into routine care. And we had surgeons at the table. We had the nurse manager from the orthopedic clinic at the table. We had the chief of orthopedic surgery actually at the table, along with our patient partners. And the clinicians were talking about how difficult it was to get patient decision aids as part of routine care due to sort of lack of time, a lack of resources. And that went on for a bit. And then finally, one of our patient partners raised his hand and said, if this is something that you really wanted to do, then the job of management is to make that happen. This doesn't seem like a lack of resources. Rather, this seems like a failure of management to realize the value and make it happen. And I certainly held my breath when that happened to figure out how that's going to land. It certainly wasn't something as a researcher you can necessarily say to the chief, but it was really powerful coming from the patient. And the patient also happened to be a senior partner at a law firm in town. So, kind of taking, we heard from Maura, taking experience from other industries, like how do things actually happen in other places? Bringing both their medical experience and other experiences to the table. And the chief acknowledged it and it said they got to work and they figured it out. So I think that really can change the dynamics in very positive ways. You go to the next slide. So there are obviously lots of challenges and things that have to be considered that, added considerations when we are really looking to figure out how do you bring patients on board as a research team member. So first of all, how do you identify patients and community partners? Sometimes there are existing organizations, Heart Valve Voice, that have really done some of this infrastructure work already. Sometimes there's not. So we actually write out job descriptions. We try to be really clear about what the role and responsibility is going to be so that we can have and set expectations about what we're looking for, and so that they can make good decisions about whether this is something that they're going to be able to do. We obviously have a range of folks coming to us. Some have full-time jobs, some are retired. So that even sort of thinking about how do we make this work. There's obviously a big training that's often needed, and ongoing support to encourage and make sure we can really maintain involvement. Sometimes it's training that the hospital requires to be a volunteer and get a badge and come and actually be on campus. Sometimes it's IRB training. How do they get involved in that research? And then there's obviously grant specific training. What are we really trying to do with this specific project, and get everybody sort of on the same page so that they can really feel like they're able to contribute. Administratively, there's a lot of issues that we've run up against trying to do this. One is aligning schedules. As I said, we often have patient partners who are full-time and want to mostly meet after hours. Others who are retired want to meet during the day, and then your clinical team. And so getting everybody together has been often challenging. The payments and the timelines are often challenging as well. So we're trying to set expectations and figuring out through our institution as to how do we actually do these payments? How do we set them up? Are they key personnel? Are they contractors? So that's been a little bit challenging. And then as a research projects, maintaining that connection, building those relationships and support. And I think Susan had mentioned this in some of her comments, Susan Perez. There's often a lag time. You do all this effort and put all this work together, you put your proposal in, and then you don't hear anything for 6 months or maybe 9 months. And then maybe you hear that it needs to be revised. So how do you kind of build those relationships and keep the connection and get people feeling like they're involved when there's often these lag times, and a lot of that time is unfunded. So, how do you figure out ways to build these relationships and maintain funding for activities that typically don't have funding, like proposal writing and the grants. So those are all things that we've dealt with and challenges we've had to do. We go to the next slide.
Hi, sorry to interrupt. Just want to make sure we're keeping on track. We're going to leave enough time for questions. Thanks.
Yep. So we have a lot of resources. I think there's actually resources are on the maybe on the web if they have with our slides. The one here that I want to highlight is there was a 2020 Summit on Measure Development that PCORI actually funded. And so this was specifically having researchers and patient participants come together to talk about how do we identify ways to involve patients in outcome and performance measures. So that might be the final report there might have some ideas for the CAHPS team and others who are looking to really build or move that patient engagement into a more decision-making type of a role. You can go to the next slide. There's an emerging evidence base. It's not huge, but there is some literature on the impact of doing this, that it does have some positive impacts on enrollment. So, studies that had more patient involvement had higher enrollment rates, maybe higher funding rates, different selection of outcomes and better outcomes. So it's still emerging, but there are some good resources if people are interested in the sort of the literature in this area. And then that gets us to our last question, or last slide. So we're obviously really excited to field questions from you all, but also really interested in your thoughts on, how CAHPS might be able to work to keep going and meaningfully identify important outcomes that might be rarely measured or might be hard to measure, but are important to patients. Sort of this idea of this longitudinal or cumulative effects, or when people have multiple health issues. I know they tend to focus maybe on one area, a cancer or a maternity or a one episode, as opposed to maybe the multiple health issues that people are dealing with. I think PCORI always often asks, if research doesn't ask the right questions, it won't find the right answers. So how might this apply to the work? And then just thinking about, ideas and opportunities for patients as collaborators and co-investigators. What are some of the concerns and how might we help make that happen? So thanks.
Well, thank you, both Karen and Susan. I mean, what a fascinating discussion to move from the CAHPS model to the PCORI model and look at ways in which they are similar and different, and sort of, or maybe PCORI raises the bar in certain ways. I think the last slide with your 3 questions, Karen, are ones that we could turn right around and ask you. How can all your experience really inform the CAHPS work? And maybe we can do that. This is not a conversation that's going to end today, but begin to sort of start and have a dialogue over time. I do want to, we don't have as much time as we'd like. We never do, but I do want to hit a couple of questions that really build on what you've already presented. But let me ask you to think a little bit more. There's a question posed by Sheila Maroney in 2 ways. One is from the perspective of preparing patients and families to help them feel more comfortable with the role that they're asked to play, kind of almost the foreign language of research. And then the flip side is, and how do you help staff or the research element to feel more comfortable with patients at the table? And I know that you sort of touched on that, but and then maybe in your answer, Susan, if you can even reflect, what does it even feel like, and how long did it take you to feel sort of empowered and able to sort of kind of be, in a sense, at the same level as the researchers that you were dealing with in the process of the PCORI grants that you've looked at? So that's really a question for both of you to think about comfort levels and engagement from the patient perspective on the research team, and then the research team's ability to assimilate the roles of patients in that process.
I can talk about some of the things we've done, and then I'd love to hear more from Susan as well. So, often when we'll have folks come on, as I mentioned, there's sort of an interview process, then we onboard them. So there really is an explicit onboarding process that includes sort of one-on-one or just getting the patient partners together amongst themselves to try to build some community and also build some familiarity with the research, the types of words and terms that we'll be using, even just like PI. Like, so it was interesting the first, you learn from your mistakes. So, we had some of our patient partners like, I don't know what a PI is. I don't know what an IRB is. I don't know what any of these things are. And then you look at your slides and you're like, oh, yeah, no one can understand even our simple slides that we have. So really, having an eye towards making sure you're giving them an opportunity in a low stakes setting, without the whole team, but, to learn and also being really mindful of how we're communicating with them. I think that was, one thing that we really tried to do with our, patient teams. And then we learn a lot from them about how do we do that better. We always tried to have more than one patient partner at the table, so it was trying to make sure that we have, there's always a little sometimes safety in numbers too. So feeling like it's not one versus, it's, this is a team with multiple views.
Yeah. Great. Susan?
Thanks. I would love to see a development of some kind of a certification program for patients to get involved so that they do feel like they have the background, the knowledge, et cetera, but it's focused from the patient participation. So we're not being trained to become the researcher or the clinician, but how can we, really be a partner in it? Yeah. And to answer your question, honestly, I'm not sure that I'll ever feel like I am an eye-to-eye partner in research. I don't know if that will happen in my lifetime, but maybe some of these younger folks that are coming up will get there for all of us together. But it's been amazing to be part of the evolution of it growing to be that point.
Well, thank you for your candor and your honesty on that. It's an interesting question from Ron Hayes, who has been a PI on the CAHPS team principal investigator for many, many years. Ron wants to pose a question about, are there any downsides to collaboration and co-designing, having patients as co-researchers? And so he elaborates to ask, are collaboration efforts sometimes prioritized at the expense of knowledge outcomes and scientific quality? Are there alternative formats other than a full co-researcher role that could be more effective in enhancing both knowledge and scientific quality, calling for maybe a more balanced approach that doesn't sacrifice for inclusion? And that's a long question, but I think you get the drift in terms of, you mentioned challenges, Karen, but are there any downsides to a full-blown PCORI model in your view, and how would you respond to Ron?
So I'll take two things. So one, I'll talk about from the PCORI perspective, just being on their grant review committees. So the scientific reviewers do rate the scientific components of it, and I think they are pretty clear. Like if the science isn't there, the patient engagement isn't going to get that over the finish line. The science has to be really strong, and it needs the patient, really strong patient engagement. But they're not going to be funding things just because it's got good patient engagement. It has to be a scientifically rigorous and strong proposal. So that's the first piece on that. I think they do recognize that PCORI has these methodology standards and are pretty rigorous in that. I mean, I think just like anything, it's just how much mind share do you have time in the day? It's more, it is more. You've got more collaborators, you've got more people, there's just more to do. So in that sense, there's probably at some point, how much, there's only so many hours in the day. So you are taking time from other activities. But, I think to the most part, you try to figure out there's such value that you can get from this. So it is, always, I guess, a balance.
Yeah. Very good. Susan, do you have any thoughts on that question?
No, I think I was more reflecting on like what I just said and thinking, I probably should explain that. It's a little bit more how we all have the imposter syndrome. It's definitely not any kind of a judgment on anyone else.
No, I understand.
Making me not feel like I'm an equal. It's just,
We have 1 minute left before we actually take our 30-minute lunch break. I do want to just pose a question from Erin Grace, who I think is echoing a question that was in your list, Karen, which is how can CAHPS incorporate patients as co-researchers? What are the concerns? How can we learn from PCORI? What sort of elements of that model actually work? And I think maybe that's a question for us to think about moving forward. I don't think we're going to answer that today, but it's a great sort of basic sort of foundational question that we can all work on moving forward.